free to jump in and share about trauma-informed care as I do this too. So trauma-informed care, I did drop this in the chat so you can refer to it, but this is a great document that teaches about healthcare settings with trauma-informed care. So the 6 key principles are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historic, and gender issues. The 4 R's of trauma-informed care are first that we should realize that it is not rare. It's very common for anybody to have trauma, psychological trauma, and we should recognize the signs of trauma so that we can respond appropriately and help patients feel at ease, and respond also proactively by integrating trauma-informed care into policies, procedures, and practices. And then the last one, hey, welcome, Christine. The last one is we should resist re-traumatization. And the example that I really like to share with that is that if a patient shares something that they're going through that we want to offer support, we need to know enough information to offer that appropriate support, but not so much to open that wound, especially since most of us are not equipped to help them process what's going on. So we need enough information to get them appropriate support, and then we want to just let them know that we know enough and we're going to work on that together. So those are the principles that I wanted to share. And then I wanted to share like a few examples. Jessica, if you could get us started with the examples that we've discussed in the past. And then Bridget, if you don't mind sharing the personal safety questions that we had been working on. And we'll just kind of feel free to jump in, ask questions, make comments to support each other. And then if you all have other examples you'd like to share, we'd love to hear from you. So please keep in mind what you might be able to contribute to the conversation.
Hi, so once again, I'm Jessica. I'm a sonographer with Sharp Steely, and I happen to share an experience that I had as a sonographer with Amy one day that seemed relevant to all of this. I think it was probably 10 or 12 years ago, which maybe isn't relevant, but I was doing a vaginal ultrasound for a patient. And in training, we were never trained to ask a person whether or not they would like to insert the probe themselves. And so I had never thought to do that. And I was probably a good 5 years into my career at that point. And she asked me if she could insert the probe. And I think by my response, which was like, oh, okay, because no one had ever asked to do that, she then felt like she needed to open up and tell me her entire story of the sexual trauma that she had been through. Because I think maybe by my reaction, she felt like it was something she shouldn't have asked. But from that point on, it's really simple for me to just say to a patient, would you like to insert the probe, or would you like me to do it for you? And I have found that in the years that I've been doing that, almost all the patients have a very positive response to that. And some of them are like, yes, I would love to do that. Some of them say, nope, you go ahead and go for it. And many of them say, I've never been asked that before. I've never been asked if I can be in that control. And I really appreciate you asking that. And I would oftentimes share with them, well, I had a patient in the past that kind of made me realize that was important. But I think it was definitely a great learning experience for me, and hopefully has changed or impacted someone along the way. And feel like it's a very simple thing to be mindful of with all of our medical procedures, that like asking one little question to give a patient control might then allow them to feel more comfortable in whatever vulnerable situation they're in.
Yeah. Jessica, do you think that that has changed your experience with those procedures and improved it for you too?
Probably, actually. I never really thought about it that way, but it makes it a little bit more comfortable for me as well, because obviously it's a very um, invasive. I mean, very, very much so in there. And so I think, yeah, it can be awkward for us as well. I mean, I think at this point in my career, I mean, a body part is a body part to me, but if you can tell that a patient is really uncomfortable, whether or not even they want that control or not, I think offering that little piece does make it more comfortable for me as well. Yeah.
Yeah.
Yeah. So,
Well, and that definitely, I mean, considering that statistically at least 25% of females have experienced sexual assault, that's a huge part of your population that you're doing this procedure on.
yeah.
So that transparency and that trustworthiness that you build as you start the procedure, that's got to be huge for a lot of those people. And it gives them, it kind of offsets that power differential that you can experience with a healthcare provider, where you're just there to be acted upon, which isn't a very fun feeling, especially if you have any type of psychological trauma, especially if it's medical trauma or sexual trauma.
Yeah, I think so too, and I think it adds to it just to explain too, because that's something I think in my career that I've gotten better at doing along the way is explaining. Okay, I'm going to be moving the probe back and forth. I'm going to be moving it up and down. There might be some pressure. Let me know if it's painful. Let me know if you want to stop. You're in control. So I think all of the little things that are really easy to say that don't, get in the way of a good, exam still make a really big difference. Yeah, I don't know.
Yeah, I had an ovarian cyst that I had a follow-up vaginal ultrasound recently, and no, it's not my favorite procedure, but yeah, definitely makes a difference when someone is proactively thinking of how you might be feeling in that situation. And that's kind of what we want to talk about is trauma-informed care as universal precautions and proactively setting a stage where the patient has the best experience they can have. And part of that is shared decision making. Part of that is making sure that there's no power differential between you so that they feel it's happening for them and not to them. So that's a
Yeah.
wonderful example. Haley, correct me if I'm wrong, but Haley, I think you had some questions or some things that Planned Parenthood shares to help patients.
Good timing after that story that you shared as well, because we do a lot of sensitive exams and intrusive exams and testing at Planned Parenthood. So one of the things that we help our providers and are constantly training our new providers is doing exactly what you just described, slowing the appointment down, describing everything that we're going to be doing and what's about to happen, asking for permission before any sort of invasive exams or testing. So that's something that we definitely encourage. And it brings to mind, we were just chatting about self swab for HPV testing and how that is not widely used. I don't know if there's like a approved one yet here in the United States. And so, little things like that where, potentially in the future, patients can collect their own STD swabs and HPV swabs to be more, trauma informed and let them guide their own care and, be in control of their own body. So we love that kind of stuff.
That's exciting. Any other thoughts that you want to share?
I would like to know if any other folks are in healthcare settings, what your kind of screening process looks like, if you do any screening or anything like that. We do screen, and it's sort of a complex thing because we want to screen and we want to, identify patients that need support, and we want to be, patient-centered and not put anyone in a situation where they feel uncomfortable, or maybe we're asking questions where there's not enough trust built. So I feel like it's a delicate balance when you screen. So I would love to hear anybody else's experience with your screening questions and protocols with providers in a healthcare setting.
I'm currently working in the emergency room and inpatient units over at Sharp Coronado. And right now in our Cerner platform, we do have questions where I am forgetting the specific wording, but we ask if the patient is in a relationship where they feel hurt or threatened, and if they feel safe at home. I believe that is the gist of our safety questions right now. However, as we're transitioning to Epic, Amy and I have been working to kind of gather some more information from people with lived experience about what would be a better question to ask to help assess for these patients and recognize the ones that need support. So I'm going to drop these questions in the chat, and then I'll also just repeat them to hear what you all think about these, because these are likely going to be the ones that we're going to input into Epic. But the first one is anyone hurting or threatening your health, safety, or well-being? And then the second one is, do you feel like you are in control of your life and your choices? Just in my personal experience working with some of these patients, that is the question of, do you feel like you're in control, is usually the turning point where they either, have a moment of really thinking about it and saying, no, and then that opens more conversation. Or, they say yes, and then they're able to describe how they are controlling, their life and their choices. And then obviously that's their decision. And then that kind of leads the conversation to where it needs to go.
Yeah. And also, great question, Haley. We, like our last meeting, and I know not everyone was able to attend, but it was our June meeting. I presented about the difference between screening and assessment. When in healthcare, everyone wants to use a screening tool, and that's totally understandable because you're screening for everything, right? However, the problem with screening tools is they tend to stigmatize patient. And Christine, please feel free to jump in and correct me if you have something to add. But that's when all of their defenses come up. So we want to do an assessment instead that it doesn't pressure a patient to do a hard yes or no. And a wonderful trauma-informed assessment to use is the PAIR tool. And if someone wants to drop that in the chat, PAIR tool, and then I'll drop a continuing ed link into the chat as well, because we all need continuing ed. So you can learn about the PAIR tool and get that continuing ed at the same time. Christine, do you have any follow-up comments about what I said?
So on that note, I would say that folks that have experienced CSEC and human trafficking know how to, okay, I'm just going to be sure with you, they know how to get the outcomes they want often. So if you're asking particular questions and they know you're screening for human trafficking or exploitation and they don't want to be identified, they will either tell you to get out of their face, or they will absolutely lie to your face if you're asking yes or no questions because they want to get you to get out of their get out of the out of their way. For example, I did try to get a survivor into a safe homework, and I was trying to prep her for the call. Like I'd already pre-called, gotten like 2 or 3 places that had beds available. And I explained to her where we're calling. She's like, okay, where we're calling? Okay, I know how to do this. But she's like, I know what I'm doing. And so like, she's like, I know how to do it. And so like people know already how to get what they need because they've had to survive. They've gotten to this point because they survived. they're resilient. People, I'm just going to be straight with you. People who aren't as resilient have not made it this far. They have died. So I know that's a little harsh, but it is just the truth. And so folks that, you know, they will either scream at someone and tell them to get out of, you know, I'm saying get out of their face, but what I really mean is they'll tell you get the fuck away from me. Like, or they'll tell you you don't know what X, Y, and Z means. So I'm just saying all that to say like the PAIR tool is really helpful because it's not a screening tool and it does say things like do you feel like you're in control of your life? Doesn't most people who are being trafficked won't respond to those words. Like, are you being trafficked? You like I had somebody once say, my life just sucks. And what does that mean? Those open-ended questions then encourage dialogue. And they do take longer than 30 seconds. It's a longer conversation. It's not going to be done in triage. So how that ended up was that patient was being trafficked, but she had some type of abuse or violence her entire life. So what she meant her life as such is like what she was enduring now wasn't that different from being abused by a parent who then had a boyfriend who was then trafficking her. His parent was actually trafficking her too. So her life did suck, but sucking meant trafficking. But she didn't have the word for that.
Yeah.
And so having those open-ended questions provide a patient with the and when you phrase it like in universal violence, like you might know somebody. I'm not saying you're trafficked. Like I'm not saying you've experienced it. You might have a friend. I mean, it's a big problem in Southern California. Like then it takes the pressure off of them to be the one. Like and they're like, oh yeah, actually I do have a friend. Oh, can we talk about how we could help them? Like together, like how can we help your friend? Like maybe they're not ready to admit that. So it just provides that kind of like the ability for them to not own up to what's going on for them, and they might be able to. So in my experience, it's way better than a yes or no checklist. If someone asks me a yes or no question and I don't want to admit to what they're asking, it's very easy to say.
Yeah. Thank you, Christine. Denise, Clarissa, do one or both of you have anything to add to what she said?
Yeah, thanks, Amy. I agree with the open-ended questions. I think those go a lot further. So I saw in the chat the two that you guys were you guys were pondering. But I think like if you ask them like open-ended as far as like what can we do to make you feel more safe, right? Or is there something that medically you're here today that I can assist you with or that you'd like to do further? Because I agree with like some of our babies, when they go in there, they know what questions they're going to be asked. They're trying to get in, they're trying to get out, and they know the routine. So if there's something that's kind of open-ended, that's like, is there anything that you're missing from today in your visit that we can assist you with that would make you feel more safe? You know, then what would that be?
Okay, that's good feedback.
Yeah, and I was actually typing as you were calling on us. I can't agree with you anymore, Christine, and exactly what you said, Ali, about the open-ended questions. Definitely a great tactic, but thinking about it from the victim's perspective, and that's what I heard Christine saying, like sometimes they don't have the words to articulate what they're going through, or they don't even sometimes even understand that they're a victim, or what is control. They've probably never had control, like she mentioned. So it's like I said, very well said. I totally agree with both of you.
Thank you. And I think, you know, your comments about control, that's where shared decision making with the whoever is doing the patient care, whether it's doctor, nurse, whoever, or if it's or like any provider, shared decision making is huge. And also offsetting that power differential. So like, yeah, like what Denise was saying, what can we do for you? Very helpful to diffuse that power differential instead of just taking control of the situation. And so I know that Kaylee, that Planned Parenthood has some questions about sexual coercion. Is it appropriate to share those? Is it okay?
Yeah, I can share those questions. Right now, the current questions that we ask, let me get these here. So disclosure, they're yes or no questions, which is why I'm loving this feedback because I think we can do better. But currently, we're asking these questions. Does anyone in your life pressure you to have sexual activity or to get pregnant when you don't want to? Obviously, we're going for a specific sexual coercion question there. And then we do ask another that's a little bit more general, similar to the first number one that Bridget shared. Does anyone in your life harm you, threaten you, or make you feel unsafe? So right now, those are two questions that our clinicians are asking.
Elizabeth, did you have anything that you wanted to add?
Hi everyone. I work at Grossmont in the emergency room. And so I did a UPC project my team did on human trafficking, to where we're basically encouraging everyone to ask the domestic violence questions, but separate, like when they get in a room, hopefully like when there's not another person or family member around. That's kind of the goal, to get them like quiet to establish the rapport. But we are excited that there's better questions coming in EPIC, because I didn't love the Cerner questions because of their being basic yes and no's. And I come from an OB background first, and I feel like the open-ended questions worked better in my previous job. So I still ask the old questions, but we couldn't get that in Cerner. So thank you for the better questioning.
We are working on that for EPIC, and then we would love to have you work with us on that.
I would just add, does anyone that you know or anyone that you're in contact with?
Ooh, I like that.
I love that.
Thank you,
Yeah.
Denise.
I love that. And I try to encourage all of our staff to just kind of lead with, it's also my job to make sure that, you know, we're taking care of all of your needs while you're here. We want to make sure that you feel safe at home. So I have to ask you these specific questions, like try to encourage them to just kind of like establish a moment of like safety and security, that we can get you to a safe space if you need that.
And the PAIR tool, are you familiar with it at all, Elizabeth?
Yes.
Okay. And it puts it in that healthcare framework, because our relationships impact our health. We want to make sure you're in safe relationships. And I used to think with that only foreign nationals needed to be educated about what their rights were, and I've been corrected since then. And I like everyone needs to know that they have rights.
Right.
Because some people don't.
They don't. You're right.
Yeah.
I do want to include as well, for those, you know, first initial triage questions, that's, I think, the goal of this, to just identify some people that might answer yes to these questions, to then trigger a social work consult. But then we'd be hoping that with increased training too, the nurses, clinicians, whoever it may be, would pass on to social work, or we have those designated nurses that are familiar with the PAIR tool, comfortable with asking those open-ended questions, so that, you know, it doesn't just stay with these two personal safety questions. We definitely continue the conversation further.
What I would love is the PAIR tool training to roll out to ER staff as a required, like, annual, you have to do this training every year, and for it to be a part of what we do in like our annual competencies, so that it stays fresh on all the staff, because we have such a high turnover, that I I wanted it to be for all staff, including our techs, including like I even want to roll it out to like the transporters for radiology. Like they kind of get more alone time with anyone in the ER than anyone else, because they're taking them by themselves to whatever testing. And like, sometimes you just can't separate the people from whoever came with them. And so my thought process was, if everybody knows the paratool and how to communicate, from the concierge to the security guards to the transporters to our techs and our nurses and our doctors, like if they all have to train on that and sign off on it every year, then it stays fresh. Especially because Grossmont's in this like epicenter.
Yeah.
Like when you look on the map, like we literally sit in the middle of where like all the highest numbers are. And like everybody here should be on top of their game.
Yeah.
100%.
Well,
Every
and
patient, every single time.
I think if you can include it in your annual SEEP training, that would be amazing.
Yes.
And you know, if we can help advocate for that, let us know.
Okay.
And
I would just add, just being in direct practice and direct service with victims of human trafficking and youth that have experienced commercial sexual exploitation. I know for certain that our babies are frequenting the ER. So for the purposes that you just listed for the, you know, the turnaround, right? The high turnaround for the training, I agree. And also too, we know that they're going to the ER, the ones that are in that survival street life, getting the hotel to, you know, to do the acts, to do the drugs, to do it all over again. They are the ones that are going into the ERs and getting those services. Whereas you know, the other kind of friends might be scheduling the visit and might be walking into the clinic, but we know they're coming to the ER and those are really those are the really hard ones that are in the life.
Yeah.
Showing up in
well,
the
and when
ER.
we did the research project, I think it said something like 68 or 70 something % of trafficked victims have been to an ER more than once in the time that they were trafficked. And so like when considering that, like they're not coming in to announce that they're being trafficked, they're coming in for a UTI or for this STD check, or if there's an arm that might be broken, you know, and they're in
Might show up as
typical
VP
like
as well.
short, right, they're here for like very short, specific,
Right.
maybe 3 to 4 hours. So it's like the time frame that we have to capture them, like we're putting them in the back in our, you know, high turnover area, and we rotate nurses over there all the time. And I'm like, we need to have more consistency in how we are capturing these human beings, because this is not,
can you
we're
clarify
not
what you
servicing
mean?
them properly.
Can you clarify what you mean by capturing?
Well, like by capturing like that, this is a person that is having something happen to them. Like we're not, I feel like back in so here in Grossmont, we have what we call D station, which is like the high turnover, low acuity. It's more like the urgent care of the ER. So anyone that's coming in for something that could potentially be screened, treated, and discharged in under 2 to 3 hours, that's where they go. But they'll have like one nurse that'll come and do their triage assessment really quick, down and dirty. Then they'll have a PA come in and see them real quick, down and dirty. Then they may have an LVN or a different nurse come in and do whatever treatment they need, and then they're discharged. So to me, everyone that's back there needs to be asking these questions, and they need to be, you know, creating a rapport. Don't be moving so fast. I get that it's a high turnover space, but don't be so fast that you're not making eye contact, that you're not establishing some form of a human connection, that you're not asking these open-ended questions, because this is where most of them, I feel, are coming to.
Can I make a comment real quick on a couple of things that were said? Is that okay with you, Amy?
Yeah.
A few. So just a few things. Like one, as far as training goes, in my opinion, and I know this has to do with funding, and that does not go over my head. So, if it's possible, for everyone in the emergency department to not only be trained in spiritual, but also trauma-informed care in human trafficking, because like that is critical. That it's critical that all the staff are trained, and so that they can see the indicators of human of human trafficking, not only in the pair tool, but so for one, and for two, like, I know you said about the numbers, but there's a lot of survivors and those who are being victimized of human trafficking all over the state that not just where there's high numbers, where there's high numbers are those who have been identified. And so there's a lot of folks that might be coming in and out of an emergency department that maybe are labor trafficked or familial trafficked or things like that that have never been identified. So over 42% of survivors are trafficked by their family, and they're never been identified, you know, or maybe they don't get identified and they're often trafficked from early childhood. So I don't want to just like have you guys focus on one typology, because then we're really missing the boat. And also LGBTQ and boys and girls, that. So just to have a well-rounded like focus on not just those who are pimp controlled on the street traffic. Yes, that happens. It does happen a lot, but there's also a lot of other types of trafficking and in that covers a lot of ways, not for one typology. So we don't want to miss other types of folks who might be coming in and are experiencing trafficking.
Right.
And that's great points, Christine, which is why we recommend the NTAC red flags document, because it doesn't fixate on stereotypes. In fact, it's quite the opposite. It helps to identify control tactics. And it doesn't say tattoos anywhere in there, because that stereotype is only one subset of a subset. So thank you for addressing that.
My big thing with that, because I get in fights with people here all the time, is that every patient, every time. Like you never know who is going to be the person, and they could be very well normal appearing, whatever normal is to you. You can't assume or judge anybody.
Yep. You
have to just assume that everybody it's happening to and walk with it that way.
Yeah, and that normalizes the conversation for the healthcare provider too, which is important, because when that critical moment comes and they're like, oh, I need to have this conversation, if they're not practiced in having it as a normal conversation, that's easily identified by the person who needs it too. So
100%.
Normalizing it for everybody is really important. Like when I have been seen as a patient and they ask me those questions, I say, thank you for asking me those questions. I know how important they are, and I validate that they're doing something meaningful. So yeah, thank you for that. Melanie, we haven't heard much from you. Do you want to jump in?
Thank you for asking. I'm really appreciating the conversation, and these are conversations that I hear in a lot of emergency rooms around so the struggle is mutual, and Christine's right. It's about funding and it's about staffing and it's about the pressure. There's so many different things to tackle, but one idea that I've suggested a few times, and we used to have the federal government used to send little cards that you could break apart, like shoe cards, and they would have the National Human Trafficking Hotline number in it. And so I would encourage people to say, you know, our hospital really cares about the community. And I know that you're out and people trust you out there. And so I'm wondering, I would like to give this to you in case you come across somebody that maybe has been trafficked. You could help us to reach people in the community. So that's one way where you're not, really, I like all of these ideas because they're all about empowering the patient, every one of these ideas. And I just love that. This is a great group, but that's another way to go about that.
And I wanted to, Elizabeth, circle back. And the reason I asked that clarifying question about, you're like, well, we aren't capturing them. There is a bias and a mentality that once you identify someone that you have to rescue them. And if they're not ready, like a lot of our experts have shared, if they are not ready, you're going to do more harm than good. And we definitely don't want to alienate someone from seeking healthcare because that causes harm.
Correct.
So,
So in
and-
my
and-
education, what I did for them was that we don't shame anybody.
Yep.
And we made it very clear because we had to double check with social work. When we first started, we didn't know that, you know, it's not like a mandated report. We have to pull them kind of a thing, that they get the opportunity to choose and decide what they're doing. And so what we rolled out was to make it very clear that they have choices and decisions and that they are in control of that, and we do not take their control away. We have those national hotline cards printed that we can leave in a room. We can have them hide it in a sock. We can offer it to them if they want. We have them in bathrooms posted in the main lobbies of both waiting rooms, and then in all of the bathrooms that they go into for like urine samples, so that they can have access to the numbers. But absolutely no shaming, and we will not allow, not while I'm here.
And no pressure to take it, because if
Totally.
someone
Because if
discovers
someone
that,
found it, then they could be unsafe, and so they have to respect that. Absolutely.
yeah. Bridget, can you unmute and tell everyone a little bit about the Safe Shelter Collaborative?
Yes, so the Safe Shelter Collaborative, it's a referral system for patients that are experiencing domestic violence, sexual assault, or human trafficking. And basically, it's a web-based system where the healthcare provider can send one referral for a request for shelter, and then there's a response time of about 30 minutes. So that person who made the referral can find out, based on the demographics, which are, non-identifying demographics, just basic information like age, things like that, to just meet criteria for whatever placement they would be going to. The response is then, yes, a bed is available, no, a bed is not available. And then the patient and the referrer can go ahead and proceed with an intake so that the patient can be placed in a safe shelter if they're wanting it. So it's obviously for patients that do want resources and do want placement and to be taken out of their environment. And then if no placement is available, they do also have an option for hotel funding. So that is something that at Sharp Healthcare we're working to be a part of, just because, as a social worker, I can call for 5 hours, multiple different agencies, complete multiple different assessments with the patient. And at the end of those 5 hours, oh, sorry, you didn't meet criteria after the assessment, and a bed isn't available. So it just is a great way to decrease the amount of times the trauma narrative is told for the patient, so that they don't have to retell their story, and then also decreases times for getting patients placed safely and then into those case management services also provided through the Safe Shelter.
One of the things that I like about it is because it is re-traumatizing to keep telling your trauma narrative. They only have to tell it once. And it goes into the web form. And Sharp we're finalizing our contract on that, Elizabeth, so you'll be seeing it soon. And I wanted to just kind of give a voice to Christine. I know it's hard for you to be heard, so I'm just going to share what you put in the chat. The cards are still being produced through the Blue campaign. There's also Futures. Sorry, what is the one that I shared with you, Bridget? Futures Against Violence. They also have wonderful cards that are well done too, and they're a little bit more open-ended, not specific to human trafficking. Yes, Futures Without Violence. And we can, when we get a local hotline, we can add our local hotline to that. It's still in process. I don't have a timeline. And then those are also a wonderful tool because they're not specific to human trafficking or domestic violence. And we know that human trafficking can look like domestic violence. And so when they self-refer, then they're just going to get the resources that they need. So, and then also Christine said, let them know they can come back anytime, which is, yes, absolutely. Or focus on the follow-up care that they need. Are they behind on their vaccinations? Maybe they need an HPV vaccination. Maybe they need a COVID vaccination. Maybe they just need a follow-up visit for what they're being seen for. If they feel comfortable, have them be seen again so that they know that their well-being is priority. And Christine also said, let them put the number in their phone under healthcare as well, which is brilliant. Also, Safe House Project has a network of safe homes. I have this video from Dr. Stucklosa, who is one of the co-founders of Heal Trafficking. And it's a very mundane example of using trauma-informed care on a day-to-day basis. So I just want to make sure I have the audio going before, there we go, share sound. And give me a thumbs up if you can hear it.
So it was Friday night at 11 p.m. I was just about to swipe my hospital physician ID badge to enter the emergency department, and there was a lot going on for me. I just needed to take a deep breath. My mom had just been diagnosed with cancer. I was entering yet another surge of COVID. And I think this was like the 4th overnight shift in a row. I couldn't even keep track at that point. So I took a deep breath and swiped my ID, and the emergency department doors swung open, and I was greeted by that familiar chaotic cacophony of patient alarm bells ringing, ambulance sirens going off, radios crackling, a patient vomiting over there in the corner. That was a really hard shift for me. There was this moment when I saw a number of my colleagues running in a direction. And in the emergency department, we don't run unless something's really wrong. So I ran. And I'll still remember it. As I was rounding that corner, I saw that a patient was assaulting one of my colleagues. And my colleague then became my patient. And the injuries that my colleague sustained would have permanent effects on their life, I quickly learned as I was caring for them. Being an emergency medicine attending physician is really, really hard. And there's a reason why emergency clinicians across the globe are burning out left, right, and center. The good news is that I have an antidote for burnout in emergency medicine. And that antidote is trauma-informed care. Now, before you interrupt me and ask, well, why would I ask busy clinicians to do something more? What I have to tell you is that I had those same questions, but the more that I've striven to integrate trauma-informed care into my practice, the more I've seen that it gives me deeper meaning in the work and brings me back to the very reasons why I chose emergency medicine in the first place. So what do I mean by trauma? As an emergency physician, I thought that when we're talking about trauma, we're talking simply about physical trauma, gunshot wounds, stabbings, motor vehicle accidents. And what I've come to learn is that trauma is so much more. Trauma is collective, like what we're all experiencing right now in terms of COVID. Also on the collective level, racism is a form of trauma. On the individual level, it's many of the things that you might think of, including assault, like my colleague experienced. So knowing this expansive definition and knowing that not just all of my patients have experienced some sort of trauma, but also many of my colleagues and staff members have experienced trauma, it's imperative, it's vital that emergency medicine take a universal precautions approach when it comes to practicing medicine and incorporate trauma-informed care into everything we do. It should really be the default mode. Now, what do I mean by what this looks like in practice? It's a framework based on 6 principles. Let me take you back to that same shift to a patient I was caring for right after I took care of my colleague. And she was a young woman who came in with a toe infection. And She was in a curtained room. There was no door. So I announced myself before entering the room, and I asked if it'd be okay if I came in. I found a stool somewhere and was sitting at eye level with her and just asked simple questions like, how can I help you today? And immediately she told me, I have this infection in my toe. I really want antibiotics and I want to get out of here as soon as possible. And she's like, please, please, please don't tell me I need a procedure. And I asked her to tell me more about that. And she shared that the last procedure that she'd had in a hospital was a really traumatizing experience. And in fact, as she was telling me this, she started to get sweaty and she looked like she would almost pass out on me. I told her, everything is your choice and there's nothing we're going to do without your permission. Also, we have strategies that can make it a less stressful experience if you do need a procedure. And I was recommending a procedure. And so together we came up with a plan that involved doing the procedure, but she was going to distract herself on her cell phone and try some deep breathing. I was very candid if something was going to hurt during the procedure. And before I did anything, including examine her, would ask her permission at every turn. What surprises me and surprises me every time is that she thanked me as a result of that encounter. And what I've learned over time is that practicing trauma-informed care gives strength not only to my patients, but gives more strength to me. I feel like I'm healing beyond treating the immediate medical condition, and I feel less burned out and more invigorated and more connected to the work. I feel renewed. Spending time in nature is one way that I recharge outside of the emergency department. And the other day I came across these gorgeous flowers called fireweed. Fireweed got its name because in London after World War II bombings, it just flourished on the rooftops. It flourishes and thrives in the fire. Today, I want us to collectively envision a world where emergency medicine is like fireweed, not surviving in spite of fire, but because of the fire. When trauma-informed care is integrated into all of emergency medicine, the trauma that clinicians and patients carry will lead to meaning and renewal, and we can move from surviving to thriving.
Did anyone notice that she used the words universal precautions? What are universal precautions in a healthcare setting?
Is it the assumption that everyone has something that like a communicable disease, for example? This is the assumption that everyone has some type of trauma, so we should be cognizant of that.
Yes, exactly. And I love that the example that she shared wasn't like some trauma narrative. It was just a simple toe infection. And so if we use trauma-informed approaches with every patient encounter and just ingrain that into practices and procedures like have been shared tonight, then it improves all patient encounters and it's hardwired for the ones where it really matters. She was great about just kind of detailing how she explained everything, just like Haley said at Planned Parenthood, before they do procedures, they explain what's going to happen. She made a plan with her, so it was shared decision making. What other things did you notice in that video?
When she said that she sat on the stool and she was eye level with the patient, I think that connection makes such a difference when you're talking to patients. You're not just another number. You're not just another check mark like, oh, I got to get through and get my patients done. My rounds, got to make my rounds before, checking out. Like that connection, getting eye level, that's what stood out to me.
That's huge. And as a person who's 6'3", I just want to say, when you're eye level, it makes a huge difference. It does. It's it goes back to that. You want to offset the power differential because a lot of people just in that situation feel very vulnerable, just totally understandable. So being at eye level and sitting down sets a tone that is an equalizing tone. So great point. Other thoughts?
Mm,
Yeah.
I liked it that she began by acknowledging that healthcare providers already have a lot to do. So
Yes.
she created a safe space that also included the providers.
Yeah. And what do you think about, does trauma-informed care help you as a provider? Does it improve your experience?
It does, and there's data that will back that up.
Mhm.
Because there's ample data that will back that up. So it is good for the providers.
And there is understandably with all of the competing priorities, it's understandable that there is pushback in implementing trauma-informed care. But once we realize that takes someone who might otherwise be labeled as a difficult patient or non-compliant, like instead of using those labels, like understanding that their response, like Christine was so eloquent at explaining in the beginning, that their response that is giving them space, that because they need to feel safe, and that's how they help themselves to feel safe. That should trigger us to, okay, am I giving them shared decision making? Have I offset that power differential? Am I helping them to feel trusted or feel that they can trust me? Am I being transparent so that they don't feel manipulated? Do I have consent to do this? Like, you can go through that and see if there's something that you can do on your side to improve their experience, and then everybody wins because it's synergistic. Yeah, Melanie had a great point that there is plenty of data to back that up. It does help with burnout as well. And that's something that we need to be concerned about with our workforce in healthcare is are we taking care of each other? So let's see. Elizabeth says, I think it should be a requirement. Trauma-informed care is universal precautions. Yeah, I think so too. Allie has a comment: in an outpatient setting, particularly to having that connection and proximity is much better than across the room when the provider is primarily typing on a computer. Yes. And the tools that we use for documenting are getting better, like voice recognition and that, so that a provider isn't looking at their screen so much. But that is a good point. And the time that it takes to document, it's another competing priority. So how do we address that? In every situation is different, but this is a very valid point. I do have a couple comments from a public health nurse that wasn't able to join us tonight. She texted me and she said, the best thing I think is asking the patient what they need instead of telling them what you think they need, which goes back to some of the comments that have already been made. And then she also says it doesn't matter if it's the ER, the telemetry floor, the ICU, the foot teams, the home visit, spending 5 minutes asking the client how they are doing and what they need shifts the whole trajectory of the visit or encounter. Makes a huge difference, just like Elizabeth said, that eye contact and making a human connection. So like I'm hopeful, especially like some of the things that we talked about were kind of human trafficking centric. But I think as we look at Dr. Stucklos' example and just think, what are the everyday things that we can do to make trauma-informed approaches the standard of care, to support the workforce and to support all of our patients. That makes a big difference in everybody's experience. Other thoughts, comments, concerns? Cash donations? Our experts, is there anything that we need to unpack a little bit more? Do you feel like?
I do just want to add the training piece in there. I think it is really important to have staff trained to at least know what to recognize, what are indicators, you don't necessarily know what you're looking for, because I think you even said it looks a lot like DV or a sexual assault, so I think I just, wanted to highlight that a little bit.
Yeah, and I think also like are the red flags or indicators we're looking at, do they include labor trafficking?
Yes.
Because it's like the stereotypes I would say are like pimped trafficking, trafficking of girls, sex trafficking, and then labor trafficking. And it's like, well, the control dynamics pretty much universal. So that's where we should start.
Yeah, I agree.
Yeah, thanks.
Great.
You don't have to agree with me, but thank you. Feel free to disagree, especially if I'm wrong. Anything else you want to add?
No, it was great discussion though. I really enjoyed this tonight. Thank you.
Thank you. I appreciate your contributions. Any other thoughts? I'm going to put the resources and some Common Spirit, which is who Christine used to work with. They developed these trauma-informed and patient-centered, strength-based language, and instead of this, do that document, and I'm going to include that in the minutes to kind of help you wrap your head around, instead of doing it this way, we should do it that way, and understanding that, the whys behind that, and all of the wonderful resources that were shared in the chat. I'm going to share those too.